Hello everyone, this is Tony Reale, physical therapist over at Baseball Rehab Expert. I'm going to take a dive into a Tommy John rehab protocol and what it looks like and some of the nuances of the program. So approximately a quarter of all injuries to major league pitchers involve the elbow injury. Obviously we know that it's under chronic stress overload and repetitive trauma overuse that leads to eventual tissue failure. Obviously, you can see some of the numbers out there. Place an exorbitant amount of stress on that elbow with every pitch. And some of the cadaveric studies that show that with every throw, that it actually exceeds the ultimate tensile strength of the ligament. So if there wasn't muscle mass and passive and active restraints that were there assisting, that the ligament would actually pop on every single throw that you make. Obviously, the most spoken about injury being the UCL. That occurs in about 85% of people with elbow pain that experience, typically on the acceleration phase or the end range cocking phase. You can palpate the UCL, keeping your elbow at 50 to 70 degrees bent in order to move the muscle mass. That way you can access the anterior band of the actual ligament that is the primary constraint with an overhead throwing motion. Some other common injuries that are associated with an insufficient UCL ligament or a ligament that may not be completely doing its job. Typically, if a ligament is not doing its job, as you go through that throwing motion and end range cocking and early acceleration, that medial elbow joint will want a gap, which then now stretches the ulnar nerve and gives it a traction type injury, potentially creating some type of friction or subluxation to the nerve, which then will send paresthesias or numbness and tingling down to your fifth and fourth digit. Obviously, the effect of one of the issues that can occur can be ulnar neuritis. However, the underlying cause may be an insufficient UCL, so we have to keep that in mind. Another one that occurs throughout this cascade is a valgus extension overload. So as you continue to throw, again, that medial gapping of the inside of your elbow due to insufficient ligament compresses the lateral side. So you see the olecranon tip that impinges on the medial posterior wall of the olecranon fossa to create some stability. That's where if you continue to throw, you'll start to get some bone spurs on that posterior elbow, and it will not allow you to get full extension on your throw, and you'll start sailing some pitches up and away. It's one of the signs and symptoms. Another one is flexor pronator strain. So again, if you have gapping on that medial elbow, the passive restraint or the UCL is not doing its job, so it'll create more stress on the active constraint or the musculature in that area to do its job to provide a little bit more stability. Obviously, if it's working harder to do its job, it'll start to fatigue quicker, and then obviously as it fatigues quicker, it becomes weaker, and eventually you'll either strain the muscle or completely pop it off its bone. Going a little deeper into ulnar neuritis, there's three stages. You get the acute onset of the radicular symptoms, again down into the fifth and fourth digits. Obviously, you'll rest at that point, maybe take some anti-inflammatory medication at that point, and then obviously as you start to throw again, you'll get some recurrence. That'll be a phase 2, stage 2, and then if you continue to try to throw through that, you will get some persistent motor weakness as you'll start to do some more permanent damage to the nerve. Valgus extension overload. Cadaveric studies suggest that valgus laxity may decrease the contact area and increase the peak contact stress in the elbow. So again, instead of spreading out the contact in the back of the elbow over a broader area, you can see where that arrow is. It's in a little bit more focal specific area. Again, it'll start to heat up that bone. You can get some bone marrow edema. More than likely, you'll start to get some bone spurring, and that'll try to assist and create added stability to that medial elbow. As well as you can see on the inside, you can start to get some radiocapitellar compression with the humerus, which potentially long term can create some arthritic changes at that joint as well. Flexor pronator strain, again, we talked about active stabilizers having to overwork in order to make up for the insufficient passive stabilizers or the UCL ligament. So again, if it's working on overtime and then it continue to ask it to throw, it starts to fatigue. Eventually, it'll start to scream and say, "I can't do this," and strain a muscle. So Tommy John, there's obviously different surgical approaches. There's a few right now. Graft choices: palmaris longus versus the gracilis. The ulnar nerve transposition. Do you transpose the nerve, or do you just leave it alone? Again, that's surgery dependent. Typically, at this point, if there's ulnar nerve symptoms prior to surgery, at this point, most surgeons are transposing it. If there's no issues with the nerve prior to, then they're kind of leaving it alone. Osteophyte, a bone spur excision. Again, you want to make sure that you're getting a surgery by somebody that's done this before. You don't want to take down too much of it because it does add some stability on the medial side. If you take down too much, it will potentially decrease some of the stability of the ligament. There has been some speculation that the gracilis is such a thick and strong tendon that it doesn't get completely revascularized and it takes a little bit longer to mature. Again, a ligament on average can take about a year or more to completely maturize. So recent research on the major league pitchers show that 64% of the graft come from the palmaris longus, whereas only 24% are coming from the gracilis. So obviously the pros are choosing more from a gracilis graft, so for whatever reason, that tends to be surgeon dependent. So Tommy John post-op protocol now. So we're talking about phase 1. Main goal is to minimize the effects of the immobilization and reestablish non-painful range of motion. So you can see the first week they're going to be placed in a posterior elbow splint somewhere in between 70 and 90 degrees for the first 7 or 10 days with no movement. They can start some gripping exercises just in order to decrease some of the distal swelling into the hand, since they're not able to move their larger elbow joint at that point. As soon as they're taken out of that elbow joint, they're placed in a hinge elbow brace in an unlocked position where they can range of motion or move their elbow to tolerance. It's initiated immediately after it's removed. Passive range of motion of the elbow joint produces 3% strain or less in both of the bands of the reconstruction and 1% strain for the anterior band of the UCL. So really in the intermediate post-op period, full elbow extension is safe and does not place any excessive strain on the healing. Again, you don't want to force anything at that point, but you're not placing any added strain on that ligament. Conversely, I would not push into flexion. Again, you only want to bend it to tolerance. Elbow flexion to 100 degrees is allowed and increased periodically throughout that until range of motion at 6 weeks is full and pain-free. But pushing into flexion will stress the ligament slightly. Moving on to the intermediate post-op phase, 4 to 7 weeks. Again, at this point, you want to continue to progress towards full range of motion with the ultimate goal. At 5 to 6 weeks, they should have full range of motion. At week 5, they tend to discharge the elbow brace, and again, that comes from your surgeon. That's the typical protocol. Week 4, we start doing some light resisted forearm to get some of that swelling out of there and start to realign some of the scar tissue fibers that are created with the surgical procedure. Start doing some scap and some light rotator cuff, shoulder strengthening type exercises. And again, at week 6, we can start doing some elbow strengthening, initiate some shoulder external rotation strengthening. And at that point, we should have full range of motion. So at this point, this is when, if cleared by your doctor, you can start the program that we are advertising here at www.baseballrehabexpert.com, which is a Tommy John program that takes you from week 6 all the way up to your year mark. It's a day-by-day workout program. It takes you self-explanatory exercises on a day-to-day basis, takes out the guesswork. Obviously, it would still be beneficial to work with somebody as well on the side to work on some of the soft tissue restrictions, make sure you're attacking some of those range of motion limitations and strength issues. But this is a program that will take you day to day, week to week, all the way through your throwing program up until you stand on the mound or get back on the field. And it is been utilized by a lot of major league players. Testimonials are on the website if you want to check that out. So how do you attain full range of motion if you don't have any? Obviously, the number one goal is to make sure that you attain pre-op elbow range of motion. So again, hopefully you had a baseline, somebody measured your elbow prior to. You don't want to make sure that you're going way beyond that. Obviously, if they took some of the bone spurs on the posterior elbow, you probably could gain some. But you do want to make sure that from a clinician standpoint that they're addressing some joint mobilizations, making sure they're doing some soft tissue to the brachialis, as that tends to scar down at that anterior capsule, that limits some of your elbow extension. You can do some joint mobilizations to radiocapitellar or radial ulnar joint if you're limited on supination and pronation or rotation of your wrist. Posterior glides, again, if you have a stubborn elbow, which tends to happen with some low load, long duration stretching, has been proven to increase some range of motion with good creep in the tissue, where you'll get some potentially some longer lasting results. And when to push, when not to push. So again, if there's decreased motion and there's a soft end feel without pain, you can push. Obviously, you don't want to push if there's pain before resistance, or if there's some type of empty end field. Something to look into from a clinician standpoint. Moving on to the advanced strengthening post-op phase, again, 8 to 14 weeks. And week 9, we start to go into that layback end range Aber position, throwing position, start doing some exercises in that position, progressing with the Throwers 10 program, gearing up towards throwing, placing some added stress on that elbow in a stepwise position. And then at week 14 is when we initiate all upper body workouts without restrictions, pending they've done all the other things that they've had to do to get to this point where they're full range of motion and strong rotator cuff, full elbow range of motion. So return to activity post-op phase. So here's this 14 to 32 week phase. This is where the bulk of the activities do occur. So at week 16, roughly, we initiate two-handed plyo med ball program to start increasing some ballistic, quick speed, endurance, muscular exercises. We do that for 4 weeks, and then we progress with the initiation of one-handed plyo med ball programs, where we're starting to stress the elbow ligament a little bit more, start gearing up towards the throwing program on flat ground with a baseball. And again, we want to make sure at this point, throughout this period, we're dealing with any surgical complications that can occur, and finding any energy leaks, whether it's in the lower extremity, your core, your shoulder, as well as your elbow and wrist. Making sure that we're doing all we can to decrease the stress that will be placed on the medial elbow as we begin to start to throw. We talked about complications again that we would deal with in that period. It does occur as a 10% complication rate with some of the things there that we've discussed in the past. Again, the ulnar nerve tends to be the most common one, as well as posterior impingement. Typically, that's involved in that cascade if they've attempted to throw with an insufficient ligament for quite some time prior to their Tommy John surgery. Tends to have some ramifications post-operatively as well. So again, return to this phase. Where do we start? We have all this time Primary goal for any sports medicine practitioner is to determine the causative effect or factors for the injury and why it occurred in the first place, and then to develop a preventative program to assist with the injury reduction so it doesn't occur again. So again, that could be surgical or non-surgical. Again, in this case, there was a reason why they ended up having Tommy John. We need to find out and investigate why we think that did. How can we reduce some of the stresses that are placed when they come back now that they've fixed the ligament? We still do need to fix some of the or address some of the issues that potentially created increased stress on the ligament from the beginning. So again, we need to address the mobility, strength deficits, develop some dynamic stability, and then integrate the whole total kinetic chain. So the elbow is just the end of a whip and used for fine motor as opposed to creating too much stress on it. So let's start with mobility deficits. As you can see, players with total rotation deficits are 2.6 times more likely to be placed on the DL due to injury. And players with shoulder flexion limitations or lat tightness were 2.8 times more likely to be placed on the DL. So clearly some of the issues that we need to work on, some posterior soft tissue as well as lat extensibility exercises are hugely important. Dines et al. In 2009 associated pathological GERD or glenohumeral internal rotation limitations on that throwing side compared to the non-dominant side with UCL insufficiency. So again, shoulder internal rotation potentially can predict elbow injury. So that's again posterior soft tissue mobility is huge. We know that with every time they throw that there's eccentric contractions that tend to densify some of that tissue in the back there. That creates decreased internal rotation of the shoulder as well as horizontal adduction. We do know that every time they throw that internal rotation as well as some of the other things, it takes up to 72 hours to return back to normal. So we need to make sure that if they're a reliever especially, but even from a starter standpoint, that after they throw that we're working on some of these things that to try to get them back to their normal. And Rhino et al. Did a similar study than Kibler in 2012, where a decrease in range of motion after a throwing event, their shoulder internal rotation decreased by almost 10 degrees, their total arc of motion decreased by 10 degrees, and their elbow extension decreased by 3 degrees. So significant range of motion limitations after throwing, and that's our job to make sure that we're addressing these throughout the rehab process. So some of the things that we do on a day-to-day basis, daily stretching program, research shows that throwing effects are immediate on limiting these range motion, as I discussed. A cumulative effect throughout a season without intervention could set up our clients for future injury. Research also shows that a daily stretching routine can combat these deleterious adaptations or potentially due to the eccentric contractions of throwing. As you can see from this video, it's not like we're doing a complete static stretching. It's more of a dynamic stretch, but we're going into flexion. Again, we know that limited shoulder flexion is causative or predictive of potential elbow injury, as well as external rotation deficit. Also, want to make sure that we're maintaining in external rotation. You can see how I'm not bringing the shoulder when I was going into external rotation to a little bit of horizontal adduction to decrease some of the strain on the anterior capsule. We want to make sure we're doing posterior capsule stretching. We know we talked about how the shoulder internal rotation limitation is hugely correlated with elbow injury or UCL insufficiency. And we're going to go ahead and work on the forearm flexors and stretching out the elbows because we said it decreased by 3% or 3 degrees rather, as well as the extensors on the elbow as well. Neuromobilizations, again, what does the research say? So in a systematic review of 11 studies analyzing the efficacy of the nerve glides, 8 of the 11 studies concluded that a positive benefit from using neuromobes in treatment of a neurodynamic dysfunction. So personally, I know performing nerve glides on my Tommy John patients anecdotally have made a huge difference. Clients or the athletes just report feeling looser, less tight, better stretch, feeling like their elbow is theirs again. And I perform them regularly and routinely on all of my Tommy John patients. And I feel like it truly did, or it does help them get over that hump a little bit quicker. So you can see in this video, I'm providing tensioners. Again, that's a little bit more risky. If you're not comfortable with that, make sure you're doing nerve glides as opposed to tensioners, where the distal is doing a shortening, not a lengthening. But you can see this one is more radially based. The first one was median based. This one's ulnar nerve based. Again, if they've transposed that nerve and made that ulnar nerve go a little bit more anterior to the lateral epicondyle, it's going to be more median nerve based. So ulnar nerve tensioner would not really do much. So moving on to strength deficits, clearly, as I discussed earlier, with cadaveric testing suggesting that the tension in the UCL during a pitch can exceed the ultimate tensile strength of the UCL, the importance of the active stabilizers of the forearm flexor pronator musculature is crucial in preventing, as well as important with the rehab of a Tommy John. Unfortunately, we can't do strengthening of the forearm 7 days a week. So some of the two interesting studies here that I have listed with Bott et al. Patients with lateral epicondylalgia, pre-intervention, passive manual scapular repositioning into adduction produced a decrease in symptoms and an increase in grip strength by 22%. That's significant to go up 20 to 25%. However, this kind of makes sense with the whole proximal stability theory. The stronger you are proximally, the stronger you are ultimately distally as well for your fine motor work. The other study there, where a group just received cervical thoracic mobilization 3 times a week, had actually more grip improvement over a 4-week period than the group that actually performed hand grip strengthening. These are some treatments that we can perform throughout the week as well in lieu of some of the forearm strengthening, but that's a significant study in my mind, so we need to make sure that we are addressing some cervical thoracic stability or mobilization. So again, proximal stability as well as mobility will increase some of the grip strength distally. So here, again, working on that proximal stability, I'm going to do some scapular PNF manuals, just working on protraction, retraction, as well as elevation and depression. Again, you can do it eccentrically, you can do it concentrically, just making sure that they're waking up that scap. Balance and UCL tear. So baseball players diagnosed with UCL tear demonstrated a decreased balance on both their stance and lead legs. Rear leg stability could lead to issues with power development, timing, as well as sequencing through the rest of the delivery, requiring your arm to catch up or having them fly open if you're not able to stay back on that back leg. Incorporate some balance, single leg balance exercises in your strengthening routine. In the program that we're advertising here, we're doing single leg exercises frequently throughout the entire program. As we know that there's not an efficient energy transfer, there's 20% decrease in kinetic energy delivered from the hip and trunk, required 34% increase in rotational velocity in order to impart the same amount of force to tennis players, which we can take that and translate that into baseball players as well, I'm sure. And that would, so people would throw the same velocity if they use legs versus not using their legs efficiently. They're gonna utilize and place more stress on their shoulder, which is significant. So again, we have in this phase we need to strengthen the whole entire kinetic chain. We have 10 months basically. What exercises do we choose? For the next 10 months, keep it fresh, challenging for the clients, for the athletes, and get the most gains, increasing that functional movement patterns. So the approach that I typically use are functional slings, where you're able to use multiple muscles and working in conjunction with each other. That way you're making them more efficient while they move. So here you see the fascial sling of the posterior oblique system. You can see that the rhomboids and the lat work through the thoracolumbar fascia in conjunction with the lateral or the contralateral glute max. So a picture, Landon leg glute works with the lat of the throwing arm. It creates tension through that thoracolumbar fascia. The action of these muscles along with the fascial sling ends up counterbalancing the rotation of the pelvis, as well as storing energy to create more efficient movement as well as power with your throwing event. So what are some of the exercises that you can do or utilize with this posterior oblique system? You see the exercises listed there on the right that we utilize throughout the entire program. A few here, so you can see on the left here, he's going to be utilizing that left glute with the right lat and rhomboid going through that thoracolumbar fascia. Obviously, this is more of a dynamic one. You could also do a split squat, stationary row. Again, you're still going to utilize that glute in isometric fashion, as well as a bird dog on the lower right. Moving on to the next fascial sling that's important with the thrower is the anterior oblique system. You can see how the pec and the serratus work with the external oblique on the ipsilateral side. The fascia, anterior abdominal fascia, working in conjunction with the contralateral internal oblique, and then the stability of the adductor on that front leg. So you can see how the obliques and the adductors are going to provide stability as that lead leg or that stride leg lands in stance during the acceleration phase, as well as rotating the pelvis and pulling the leg through during the deceleration phase. Activation of these adductors occurs in concert with activation of the ipsilateral internal oblique, contralateral external oblique, pulling the trunk in the necessary direction to propel the shoulder to throw. So again, obviously we need to strengthen those adductors, but we also need to have extensibility in the opposite side as well in order to allow the movement to occur. Some of the exercises listed there on the left are, again, some of the exercises that we use throughout the entire program. We'll go into a few of these specifically. The one on the left, plate chop lunge, you can see how that lunge lead hip internal rotation is going to assist with deceleration, which can decrease stress on the posterior cuff as well as the elbow. So again, we're only going to throw as fast as our body, as we know we can decelerate. So again, this is a good one where that adductor is working in concert with the obliques, but also from the posterior side, you're getting some deceleratory from that hip. And then you can see on the right, single arm, double arm kettlebell swings. Recent studies showed that it's high EMG activity of the glute max as well as the glute med, which is important as well. The lateral system functional sling, again the quadratus lumborum, glute med and min, work in concert with the tensor fasciolata as well as the contralateral adductors. The lateral sling is going to provide frontal plane stability using these force couples, keeping the iliac crest towards the stable femur while the opposite quadratus laborum and the obliques by elevating the ilium. So again, this frontal plane stability is crucial in the longevity of the lumbar spine, especially with a sport such as baseball where we're rotational. We know that the lumbar spine is not great at accepting or doing a rotational movement, so we need to make sure that the frontal plane is stable, so we're working through our core up into our thoracic spine where most of the rotation should occur, as long as with our hips. Again, some of the exercises of the lateral system that we utilize in this program are listed there on the left, and we'll go through a couple. So the exercise here on the left, again, we're going to utilize single leg balance, and we're going to utilize that lateral system and go side to side, but we're going to balance on that left leg, but we're also bringing that other knee up, similar to a balanced position for a baseball pitcher. We're utilizing a lateral step up with the weight in the opposite hand, working on that quadratus lumborum and frontal plane stability of that lumbar spine, as well as side plank with hip abduction. Again, we're working on that longevity of that lumbar spine and frontal plane stability. Another fascial sling, the deep posterior longitudinal system, the erector spinae, sacrotuberous ligament, ischial tuberosity, as well as the hamstring. So that posterior oblique or posterior longitudinal system all the way down for triple extension. Again, some of the exercises that are listed there that we utilize throughout the program. Go through a few. You can see here on the left, going through triple extension as we bend down and then extend at all three joints as we go into a rotation. TRX, lifting that glute as well as hamstring activation, as well as the glute ham machine. Again, all exercises of that deep posterior longitudinal system that we utilize throughout the program. Moving on to phase 4, where we're starting to get closer to return to activity. So we've taken the client through all the exercises and arm care programs. When do we start performing baseball-specific exercises? So again, everybody's different. It really depends on how hard they're attacking their rehab and how hard they're working in the weight room with the intent, not just going through the motions. But typically, on average, throwing flat ground starts at 6 months post Tommy John, off the mound at 8 or 9 months. For a game ready for a position player, typically happens around that 10-month mark. And game ready for a pitcher is usually around that 11 to 12 mark with this program. Again, research shows from an average person from a position player is ready at 11 months, and for a pitcher is at 14 to 16 months. So this program, if you're working through, can expedite some of that. Again, everybody's different. Everybody has a certain hiccup, so it's not guaranteed. Nothing's guaranteed, but again, we've had a lot of success with a lot of different guys that have utilized this, that have come back in those time frames. Hidden progression, again, depends on the time of the season, whether throwing or hitting occurs first. However, I don't like to add both of them at the same time. Typically have about a 4-week gap in between. That way they can kind of add some of the stresses, get used to it before we add a different one. So depending on where they're at, typically start, obviously if they can DH or pinch hit, that type of thing, and recoup some of the season, then obviously we would start a hitting program first. If that's not the case, then throwing obviously is definitely the longer of the two. But again, that's individually based. From a hitting perspective, we can start with one-handed drills, two-handed swings, normal swinging, fielding progression. We're going to do some ground balls, footwork type drills where there's no throwing. We can do that earlier prior to throwing. And then obviously running bases. Again, running depending on whether they use their gracilis or not. I usually don't initiate running on a treadmill indoors until about 8 weeks, and then allow them to kind of build up on their own for a good 2 to 3 weeks prior to doing some outdoor running where they're starting to do a little bit more sprints and then obviously progress towards base running. Success rates of Tommy John surgeries. Again, what is the latest success rates in professional baseball? And Erickson et al. Took pictures from 2010 to 13 that underwent reconstruction, showed an 83% return rate with Major League and 97.2% with Major League and minor league. So obviously results have been great. Took a little longer, on average 20.5 months. However, the career after surgery, as well as fewer innings pitched post-surgery, were noted from those players, 179 pitchers. Interestingly, in the most recent study, only 67% returned to their pre-surgical state. And of those, 57% returned to the DL for throw and arm injury of some sort, and a quarter of them being elbow-related. So what does this mean? Tommy John arm care, rehab, and daily monitoring of the range of motion, strength, etc. It needs to continue throughout their career. So again, you've worked your butt off for a year, you got back into the game, you're pitching, you're playing. The programs that you've been performing, they don't just go to the wayside. Hands-on treatments that you're getting, they don't go by the wayside. You have to continue this throughout the duration of your career. Obviously, we know with you playing, limitations occur on a day-to-day basis. It's important for you to work with your athletic trainer or sports medicine practitioner, physical therapist, on a day-to-day basis in order to monitor these things to decrease the stress off them. And I believe if you were to do that, some of these numbers, DL post-surgery as well as elbow-related issues post Tommy John, would and should decrease. So again, we need to continue and perform maintenance in order to decrease the stress off the elbow. And how do we do that? These day-to-day management things on addressing mobility deficits, working with your trainer at your school is of utmost importance, building a relationship with them, but also learning some of these exercises on how you can do this stuff on your own and taking onus on your career path and taking responsibility on making sure that you're putting your body in the best position to sustain a season. One of the ways that you can do that is by some soft tissue, some instrument-assisted soft tissue mobilization. So again, we talked about the posterior cuff in throwers, how it tends to get densified due to the eccentric contractions from throwing and deceleration. We need to address this, as we know that internal rotation deficits do have a correlation with UCL insufficiency or increased stress. So the utilization of these instruments have been reported to produce a localized inflammatory response, reduce some of the scar tissue or densified tissue, break down some scar tissue, and obviously ultimately increase range of motion with shoulder internal rotation as well as shoulder horizontal adduction. Here's a video here of some scapular mobility. Again, we talked about how everybody talks about scapular stability. We also need to make sure that we're addressing some scapular mobility as well. We know that the scapula is just a resting position off the thorax. However, after some Tommy John or any other type of surgery, people tend to hold their arm in a different position. They tend to get those musculature kind of locked down in there. We need to make sure that we're able to distract that medial border of the scap off the thorax. We need to make sure that we're framing the scapula. That way we know that it can move in all sorts of directions: upward rotation, downward rotation, elevation, depression, as well as medial rotation, external, lateral rotation. So again, some of the exercises we can do sometimes, if the scapular is not moving correctly, that can show up in shoulder issues or as well as elbow issues. Moving on the chain again, cervical mobility and flexibility. You can see on this exercise that I took from SFMA, foam roll press. I love this exercise, addressing limited cervical rotation range of motion. Obviously a lot of guys have this upper cross syndrome, forward head posturing, and we know that shuts down the lower trap, which has been linked to shoulder impingement. Shortens the levator scap, which downwardly rotates the scap. Again, Shirley Sarman work on movement dysfunctions. That's going to lead to increased upper trap activity and decreased serratus. So again, we need to make sure that we're addressing this prior to having them do some shoulder exercises. That way we're giving them the best ability to activate their musculature. Moving down the chain again, thoracic mobility. We know that the thorax position again affects the scapular position. We need 13 to 15 degrees of thoracic extension to have normal shoulder elevation. Thoracic spine manipulation, if you're working with a clinician, can reduce pain by 51% and increase shoulder elevation by 30 degrees in shoulder impingement patients. Thoracic spine rotation is huge in baseball. Obviously, as we know, it's a transverse rotational sport. We need to make sure that we have in rotation that the rotation's coming from the T-spine as well as the hips and not from the lumbar spine. Again, here's some more T-spine mobility exercises. We can see on that bottom, the one we're opening up, and then we see this other one here, again from FMS, where we're doing some prone to supine rolling. We're getting some shoulder to hip disassociation, which again we know is important from a throwing perspective as well as a hitting perspective. We know that it's going to increase some pec major and minor length as well. As we go to roll, we're stretching that. Again, thoracic mobility stressed, very important in baseball. Lumbar spine, again, moving further down the chain. Again, you can see this one from FMS, reach, roll, and lift. We know that the lat attaches to that thoracolumbar fascia, which can, if you do have a tight lat, it will lead to excessive lumbar lordosis, and that also is linked to shoulder pain. Anterior pelvic tilt leads to thoracic kyphosis, which again limits thoracic spine extension needed for shoulder elevation, which again, if you're not able to get shoulder elevation, you're going to drop your elbow and potentially lead to elbow issues. You need to work on as well as anterior core and anti-lumbar extension rotation exercises, as you can see with this one. That's not allowing to rotate as well as you're going into extension. So this exercise is a great one for a baseball player. We need to make sure that we're working on hip flexibility, lat flexibility to better align the pelvis. So again, if we're not addressing somebody has thoracic kyphosis and we keep working on T-spine extension, we're not getting the results that we want. Make sure that we're going further down the chain and addressing the lumbar spine, which then affects the thoracic spine, which then can potentially give us better results. Again, moving down into hip mobility, we can see on this video here that we're doing the hip matrix in all three planes of motion. Again, we know that the front leg hip internal rotators tends to get tight on a pitcher as they continue to eccentrically load that back hip or that glute. We need to make sure that they're able to come around to completely decelerate their arm, as well as the back hip, the stance hip, needs to make sure that we have adequate external rotation in order for them to be able to disassociate and not fly open early because they're limited on external rotation on that back hip. So in conclusion, we want to make sure that we're doing regional interdependence. We're not just treating the elbow, we're treating the cause. So obviously the cause can be anywhere throughout the body. We talked about energy leaks can occur at the ankle if we're having limited ankle dorsiflexion on the stance leg, not able to activate the glute, whether it's hip external rotation limitation on that back leg, allowing them to fly open, limited adductor flexibility on that back leg, not allowing them to stride. So again, they're going to have to fly open and then take out their legs. We want to make sure that we assess alignment, mobility deficits, strength deficits, create some dynamic stability, as well as integrate that entire kinetic chain through fascial slings so there's a more efficient movement pattern. And again, we know that success rates for overhead throwing athletes coming back from Tommy John in Major League are only 67%, 97% from Major League and Minor League, but in order to return to their pre-surgical state from a number standpoint, it's only 67. So we want to make sure that we're trying to avoid Tommy John if we can. Obviously, success rates are coming back, and we're hearing it frequently every season that guys do come back. So if we do have to come back, it is a safer surgery. Again, we need to make sure that we continue to perform even after we go back to playing our daily maintenance programs in order for us to not return back to the disabled list or re-injure something. I would like to just thank everybody for listening for the last 45 minutes. If you guys want, you guys can go on the website, www.baseballrehabexpert.com. If you guys have any questions about the program, about throwing, return to play, or any other questions that you guys have, email me at info@baseballrehabexpert.com, and I'll get back to you as soon as I can. Thank you guys. I appreciate you listening.